The Jerry Pal podcast is brought to you by Archstone Foundation. Archstone Foundation, improving the health and well-being of older Californians and their caregivers.
And supported by listeners like you, many of whom have donated on the Jerry Pal fundraising site, which you can find at www.jerrypal.org, big blue button, or through reviews, stars on your favorite podcasting app. Big thank you. Welcome to the Jerry Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, I have a feeling I'm going to love this podcast. Who do we have with us today?
We've got an all-star lineup. We have Drew Rosielle, who is a palliative care doctor at the University of Minnesota. He's the editor of Fast Facts. He's the founder of Pallimed and the author of two recent posts on Pallimed titled Simplifying Opioid Conversions and Opioid Equianalgesic Tables Are Broken. Welcome to the Jerry Pal podcast, Drew.
Yeah, thank you. Yeah, delighted to be here.
And we're delighted to welcome back to the Jerry Pal podcast, Lynn McPherson, who is professor and executive director of advanced postgraduate education and palliative care at the University of Maryland, Baltimore School of Pharmacy, and author of Demystifying Opioid Conversion Calculations, second edition, which we discussed on a prior podcast. Welcome back to the Jerry Pal podcast, Lynn.
Thank you. It's a pleasure to be here.
So before we get into the topic of rethinking opioid conversions, Drew, I think you have a song request for Alex.
Yeah, my request is Unsatisfied by the Replacements. And I chose this because Replacements are a legendary Minneapolis band, and because I'm unsatisfied with equianalgesic tables and other aspects of how we talk about opioid conversions.
Right. Let's hit it, Alex.
Look me in the eye and tell me you're satisfied. Hey, are you satisfied? I'm so dissatisfied. Hey, are you satisfied? I'm so dissatisfied. Hey, are you satisfied?
Drew, you are not satisfied with equianalgesic tables, or in your Pallimed post, calling him EATS, which is
disturbing. It's disturbing.
That was pure laziness. I just didn't want to write equianalgesic tables 50 times, so I just said EATS. And please, let's not call them EATS. Yeah.
Why are you so dissatisfied with equianalgesic tables?
I mean,
yeah. For those who don't, what is an equianalgesic table? Lynn, I see you holding up. What are you holding up? It looks like an Excel sheet.
No, it's an equivalency table on a laminated card.
And what's an equivalency table?
It is how you go from one opioid to a different opioid, depending on the opioid and the route of administration. Looking at, you could call it equivalency, you could just call it a conversion also. It depends on the clinical situation.
Okay, so we want to switch from, let's say, morphine to dilaudid. We pull up our handy dandy equianalgesic table or conversion table. It tells us roughly how much one drug is comparable to another drug. We do a conversion. We may account for things like cross tolerance and just dose reduction, and it gives us a number. Is that right?
That's correct. They put you in the ballpark at least.
And Lynn, you've been doing this for a long time. How long have we been using these equianalgesic tables, conversion tables?
Oh, I think the first one I saw came out in New England Journal probably 30, 35 years ago from Michael Levy. And they have changed a little bit since then. The first one that came out said that 10 milligrams of parenteral morphine was 60 milligrams oral, until we quickly figured out with chronic dosing, we have to account for the therapeutic effect of the morphine 6-glucuronide. So that did adjust that variable. But since then, it's been pretty constant.
Yeah.
Until the second edition of my book, that is.
Isn't there another?
So like 10 milligrams of IV morphine is 30 milligrams of PO, which is 1.5 of IV dilaudid, which is, I got that table memorized, burnt into my head.
Yeah.
Although I've started to hear a lot of people using opioid kites before now. Drew.
I just want to add that there's more to equianalgesic tables, because what's important, and this is important to my discussion of them, is that the way the tables are structured, every single a quantity in those cells on that table are considered equianalgesic. So every single entity there is per the table in an equianalgesic relationship to one another. So that's one aspect of it, and then sort of going along with that,
analgesic, that 10 milligrams gives you the same analgesia of IV morphine as 30 milligrams of PO morphine. That's equal.
That's the idea,
right?
Yeah. That's the good idea behind equianalgesia.
Before we get into Drew's issues with equianalgesic tables, I think there's another reason for the existence of equianalgesic tables, at least to my mind and the way I use them. And that is to try and figure out, is this patient on a little bit of opioid, a medium amount of opioid, or a lot of opioid? And so when I see a patient and they're on like 3 different opioids, I'm trying to figure out, okay, is this a little bit or is this a lot? Then I can convert it all to oral morphine equivalents, or OMEs, it's commonly referred to. And I have a sense, I have like a gauge in my mind of what a little bit of OME, opioid, oral morphine equivalence is. And I have a sense of what a lot is. And so that's another way in which I use the equianalgesic tables. Does that sound right?
Well, I think being sensitive to that very fact is the whole crux of what we're talking about here. I don't care whether you use an equianalgesic chart or a multiplier or a divisor. Really, as I said to begin with, this kind of a calculation just gets you in the ballpark. The whole shoot and match is using a process. I advocate a 5-step process, which is, assessing your patient, calculating the total daily dose, pulling the trigger on the actual math, whether it's a ratio or a multiplier or a divisor or an app or whatever. Step 4 is adjusting it for your patient. And step 5 is the most important, monitoring the patient. So when I say this literally gets you in the ballpark, I don't know which of the 40,000 seats is yours. This just gets you admission to the ballpark.
All right, maybe we should turn it over to Drew now. What do you think, Eric?
All right, Drew, you say opioid equianalgesic tables are broken. Why is this broken?
Yeah, well, I think there's a long answer I have, so hopefully you'll tolerate me. I was trained in how to use them, in the early 2000s, and have been teaching them for years myself. Over the years, I've realized that I stopped using them because of I didn't like the way the math that equianalgesic tables encourages people to use involve cross multiplication, which I think scares a lot of people, and it's easy to mess up. And I realized over the years I had most of my fellows and residents I would teach them these things and they would not use them. They would go to online calculators because they were too scared of the math and making mistakes. And as I've been blogging about this for a couple of months now, I'm really trying to find anyone who loves these things and it's like dang, this is Dr. McPherson aside, that this is really the superior way of talking about how to calculate opioid conversions. And I think part of it's the math, but I think what really happened is I think the story here is that in 2018, MD Anderson published this really landmark study by Dr. Reddy and her colleagues about going from IV dilaudid to oral dilaudid, oral hydromorphone, I should say, oral morphine and oral oxycodone. Landmark study, and really the best that had ever been looked at, especially in our population, in sort of a cancer serious illness population. And those conversion ratios that came out of that study were substantially different than what the conversion ratios that had been in the what I call the classic equianalgesic table. And just to take one example, the table that says 1.5 milligrams of IV dilaudid is equianalgesic to 30 milligrams of oral morphine. right? I think most of us are familiar with that table. That's a 20-to-1 ratio, right? What MD Anderson found was really more of a 10 ratio. So the oral morphine dose would be about 10 times the IV dilaudid dose, not 20 times the IV dilaudid dose, right? So there were big differences. And so Dr. McPherson, as far as I can tell, like she's really the only person in our professional community who in any sort of like serious public way said like folks, like we need to do something about this. Like we need to respond to this really good data because well, as Dr. McPherson is in other venues have talked about extensively, like the whole thing is based on sort of flimsy data anyway, but like this dilaudid, IV dilaudid data is really quite in some ways the best data we've got. And so she updated an equianalgesic table and published that in the second edition of her book. But that there was all sorts of fallout from that me and many of my colleagues experienced. And just to, I know this is like we're talking about math, and so that makes it all a little complicated. But think about it this way: so the old table, 1.5 milligrams of dilaudid times 20 to get the oral morphine dose. The new table, you'd multiply it by 10. Maybe it's 12 on your table, but it's something much smaller, right? And so that was good. I think that was a good conservative change based on science. And everyone were like, yes, good. The problem with equianalgesic tables is that every one of those relationships is fixed and bidirectional. So if you make one conversion twice as conservative, going from IV dilaudid to morphine, you make the reverse conversion, going from oral morphine to IV hydromorphone, you make that twice as aggressive. So you can't change it in one direction without having this mirror image change on the other direction. And so a lot of people were like, gosh, like this new table, this wants me to put people on twice the amount of IV hydromorphone that I was used to. I'm not comfortable with that, right? And so that was a big part of it. Well, and the other part of it.
Wait, before I'm going to hold right there. I love your thoughts on this too, Lynn, because I think like when we think about some other tables, like a fentanyl conversion chart, we usually think about that's a unidirectional table. You don't go the other way because incomplete cross tolerance is already built into that. We'll talk about incomplete cross tolerance, but there's some dose reduction. How should we think about kind of some of this new data around these conversions, like from IV dilaudid to PO? Sure. Your thoughts on that?
I mean, I think the bidirectionality question is a very valid question. I think, the whole thing we're talking about here is process versus content. So let's talk about the content Dr. Rosielle just mentioned. So we're all believers in evidence-based practice, so which, of course, is the three-legged stool of the patient's wishes and beliefs, the clinician's experience, this is how we've always done it, and evidence. So I don't think the patient's got a big dog in this fight about saying how we should do these conversions, which brings us down to we've always done it this way, which I can accept unless we have evidence. So as Dr. Rosielle just pointed out, Dr. Reddy did a wonderful study transitioning off of IV dilaudid to the oral opioids. So I saved it just for you, Dr. Wydera and Dr. Smith. I actually reached out to my girl, Dr. Reddy. I said, girl, you got to bail me out here. I know that MD Anderson has, the way we've always done it, is a 10-to-1. They take 10 times the oral morphine, 1/10 of that is the IV hydromorphone. I said, we need to do the study in reverse. So she said, okay. So she pulled 22 charts and she actually did it. It's just a pilot. And the median conversion, hold on to your head, is 12.5, which is exactly what I have in the chart. So it is bidirectional. Now, is that enough, this little pilot project? Of course not. We're talking about doing a multi-center trial, but MD Anderson for decades has used the 10-to-1, and this 22 chart audit has shown the median conversion was 12.5 and the mean was 10.5. So it's exactly what I have in the chart. Now, before I see you inhaling, let me finish. I mean, really, the best chart would be like 10 milligrams of IV morphine is 20 to 30 of oral morphine. But I think people would have an embolic event if you gave them a flipping range. So I was not fond of doing the range idea. So the chart that I have in my book and that I use in practice, and so many healthcare systems have adopted already, is the very best cutting edge data we have. But we still, regardless of how you do this calculation, have to temper it with clinical judgment.
So I got two questions. First is, if you do a study looking at your standard of care, which is 10-to-1, and the results turn out to be 10-to-1, how important is that versus like if you looked at a lot of different institutions with a lot of different standards, some using 20-to-1, some using 10-to-1, and seeing what the average is there. Because I've been using the classic, 1.5 to the 30 PO morphine. Gotta say, over probably like nearly 20 years of use, I've never really run into big issues with that conversion. Thoughts on that?
I'm willing to bet that you temper that calculation with your clinical judgment, though.
Yeah, and I usually do a 25 to 50% dose reduction, which gives me 10 to 1. But if I use the 10 to 1 and then I dose reduced by 50%, I'd probably be significantly underdosed.
Think about why we're doing these conversions. I mean, I know it's not 100%, but when you look at switching somebody from oral morphine to IV dilaudid, it's usually because their pain is not well controlled. That is not an equivalent conversion. That is just rotating. When you look at somebody who's on IV dilaudid and you're going to send them home now with oral morphine, that's more of an equivalency because their pain has been controlled. Do you see what I'm saying?
If we just had simple conversion tables, which had, when going from IV morphine to morphine, do this one. When going from morphine to IV hydromorphone, do this one. And those ratios can be different. There's a whole edifice that we've created of doing these workarounds for these equianalgesic tables that have forced into ranges that like all of us are uncomfortable with. Like I never, even though I worked for 20 years, like you did, Eric, with the 20 to 1 IV hydromorphone to morphine ratio, I always radically dose reduced, right? And that was my practice, right? But my point is that's unnecessary, right? It's unnecessary because we can have our cake and eat it too. We can have conversion tables which use evidence-based ratios as much as we can find them. And those conversion tables don't have to have bidirectional ratios. They can have conservative ratios every single way. Instead of saying we have one ratio and it goes in both directions, but everyone kind of knows, wink, wink, read this book. Everyone kind of knows that when in this way, you just have to really, really dose reduce, right? And my proposal is that workaround is not very necessary. Nuance is always going to be needed. Clinician judgment is always going to be needed about patient mental status, patient frailty, the circumstances of the conversion. But that a lot of this extra work that we ask interns to do, we ask hospitalists who don't know what's what to do, all of this could be, it's not going to be taken away entirely, but would be mitigated if we had conversion tables that weren't fixed and bidirectional. Because the other thing I'll add is that if you change on that equianalgesic table, if you've gotten your data and you change morphine and hydromorphone and you change the number for morphine there, all of a sudden, you've now changed the morphine ratio between oral morphine and oral oxycodone, oral morphine and oral IV morphine, right? Like these tables, because the format of them is that everything is in fixed relationship with each other. You can't just nudge one thing based on a new study. So everything crumbles. And why? What I asked was why. We can just do it easier. It's easy.
What does easier? What does easier look like to you, Drew? Because having like 20, 30, 40 different tables.
Oh no, it's more than that. I mean, if you look at the 10 drugs I have in the chart and you do every possible calculation, I calculated this last night, it would be 560 lines of data. I hope you got a really big lab coat pocket to fit that in.
How would that work in your eyes, Drew?
Every box in my table is defensible with data to back it up.
How would that look like to you, Drew?
I mean, I published a draft version of it on the blog. Yeah. It's compacted. There's more cells in it than the average equianalgesic table, but there's not 500 cells. I mean, you can add them up.
If you did them all, it would be.
My table has the vast merge. I mean, well, it has all of the conversions that would happen between various formulations of morphine, oxycodone, and hydromorphone that are available in the U.S. It's like 18 entries long and it's compact. I'm not sure that it would. Because I don't understand the 500 entry thing.
You took any, like I have 10 opioids in the chart, then you've got an oral column and a parenteral column. If you took opioid number 1 and went to opioid number 2, and then 1 to 3, and then 1 to 4, and so forth. Honestly, I can calculate that. It's like 500 or 600 lines. But more importantly, when I looked at your appendix, Dr. Rosielle, you've the Institute of Safe Medication Practices says you should never have order sets or charts or anything where one drug name is very close in proximity to another drug name, particularly if they sound alike. Hydrocodone and hydromorphone, ISMP recommends using tall man lettering because it's so confusing. Even in your chart on one line, even within the same line, you've got one multiplier and one divisor. I personally find your chart way more confusing. As a matter of fact, one point you and I agree on is opioid conversion calculators are probably the work of Satan. I would actually rather somebody use an online calculator because then at least I don't have to worry about them using the wrong line, picking up the wrong line. And to your point that you and your fellows have difficulty doing a ratio calculation. This reminds me of Dr. Meyer's very famous video about people are not born knowing how to intubate somebody, nor are they born knowing how to break bad news or have a goals of care conversation. They weren't born knowing how to do a ratio conversion, but they did learn in third grade. So if they've forgotten what Miss Peach taught them in third grade, it's literally would take you 15 minutes to walk them through that. I really am not buying that it's too complicated to do A over B equals C over D if you know 3 of the 4 variables. Come on.
And Drew, what I'm also hearing from you, though, in your posts is maybe there's something different about people doing primary palliative care and pain management versus specialty palliative care and the level of knowledge they need to know. Is that right?
Well, of course. Yeah. I mean, I think part of my argument, again, for people who are listening, they can look at the conversion table, which I would really want to point out was just a proof of concept draft that I put out there.
And we'll have links to Drew's posts, which also has the Dropbox version of his table and box version.
Yeah, there's an annotated version as well that I put on there with just kind of like why I chose those numbers. It's nothing remarkable, just ready data and stuff like that. I want my fellows to have read Dr. McPherson's book and to know the content really well. I expect my colleagues to know that. There's a large amount of sophisticated, nuanced knowledge that all of us who do high-risk pain management for serious ill patients need to be aware of, right? But I just don't expect my medical students, residents, and generalist colleagues to do that. I mean, to have that, and so part of my proposal is again that we can actually use very similar information. That's what's on the equianalgesic tables. We can put it in a format that the math is a single multiplication or division calculation, not several, and you can make your own judgments about whether it's compact or not. I guess I'm not putting in tramadol and meperidine, but I feel okay about that.
I want to come to Drew's defense a little bit here. And I think, Mary, there may be some agreement here. And we went through a little bit of this with ePrognosis, our online prognostic calculators. And the idea was, why in this day and age have... in a prognostic calculator, you take all these potential elements of risk, right? You take somebody has disability, you take their age, their gender, you take their chronic conditions, maybe they have heart failure. You take their function, take some lab values, right? And all those things are related to risk. And you could put them together in an equation. And the old way of doing this is that there would be kind of like pencil and paper, like an equianalgesic table. And you'd see, okay, you get so many points for being male, so many points for having heart failure, so many points for having disability. And then you'd add it all up. And then you'd go to a risk score sheet, said if you have this many points, that corresponds to this mortality risk. And we realized, you know what? We should just put this on the web, because why have people get out their pencil and paper and do all these calculations? We should just have all the calculations hidden, and that people can just enter their values and then they get the result. So why not do what Drew's suggesting and just say and I think I heard you say, Mary Lynn, earlier that, you'd rather they go to the web and do this. Why not have one place on the web? And if the conversions are complicated, just take that away. Remove that element of error.
I can tell you
have
why.
it all, online, easy to use, no algebra necessary.
I wish that with all my heart, that I could tell you, whether you use Dr. Rosielle's approach or my approach or the Man in the Moon's approach, that this is a cookbook approach and that your mother could do it. But that's not the case. I have very good research. We've done several projects looking at people using these online calculators, and the disparity in resolution to hypothetical cases is so disparate, it would knock your hat in the creek from between program to program to program and between users. The problem with an online calculator is people put in the numbers, they crunch through it and say, Eureka, I've got the answer, and they just turn off their brain. I actually had a student once who did a calculation online, and after he did it, he's like, wow. I said, what? He said, it's like 1,000,000 milligrams of morphine. I said, well, what do you think of that? He said, well, we're going to have to order more morphine. I was like, oh.
So the central supply
yeah,
depot.
I think we all agree that's not a good look. So I think people tend to turn off their brain with those online apps, and they don't think about, why I like the 5 steps, because was the patient in pain with the patient and not in pain? To your point, was the patient on 30 milligrams of morphine a day or 300 milligrams of morphine a day? Dr. Rosielle and I agree that fentanyl is a hot mess when it comes to doing the conversions. What's the patient's body habitus? I mean, there's so many variables that go into this. And I think we do our learners a disservice, even if they're not going to be a palliative care person when they grow up. I mean, even primary palliative care skills when it comes to conversion calculations. I think they need to understand these basic concepts, or you know what, they should not be in the game and they should call us instead.
Drew, thoughts on that?
I agree in part, right? I think that I want my residents and medical students and colleagues to do more than a math calculation, right? And I think, and obviously there's no light between me and Dr. McPherson on that. And I think probably almost everyone who does this work, right? So that but fundamentally, I think we have structured this as we've made it harder than is necessary. And including, really because of the structure and the nature of equianalgesic tables, similar information with simpler math can easily be presented to our colleagues. And I think it's time to do that. And especially because I'm hoping, there will be additional data that come forward, which will help us make these tables better. And every single time, however, that data comes forward and we have to adjust one value on that table, it's going to mess up everything else, right? And it just seems to me like we don't have to do that. If we didn't structure the information as an equianalgesic table and instead just had it as a simple conversion table off oral morphine, conversion table off oral hydromorphone in a simple compact way.
I think another benefit of looking at an equivalency table is it allows the learner to gain a deeper appreciation of the relative potencies, which you're not going to get with a multiplier or a divisor. For example, it shocks me how many people don't know when there's a medication where the dose is different, whether it's oral or parenteral, they have to really think a long time, which is the higher and which is the lower number. I mean, that's pretty straightforward. If it's IV, you're putting it in the systemic circulation. We don't have to worry about bioavailability. But if I can look at a chart and see, okay, 20 milligrams of oral oxycodone is about 25 or 30 of oral morphine. Oh, oxycodone is actually a little more potent than morphine. What the heck? And hydrocodone is about the same as oral morphine. So I think that visual really helps people understand these concepts better.
And how much of this debate is really just about processes? And you end up in the same value anyway. So for example, I use the traditional opioid conversion table, equianalgesic table. And probably for the vast majority of and my process is I'll find out if they're in pain or not. I will look up their total doses. I will convert using the table. And then I'll usually do a 25 to 50% dose reduction. And then again, individualizing it to the patient, how much pain they're in. Thinking about, are we switching different types of drugs? Am I switching from morphine to morphine or morphine to dilaudid? Mm-hmm. And then I'll evaluate. That sounds very similar to Lynn. Lynn, that's basically your 5 steps right there, right?
Process, exactly. I mean, is the patient possibly experiencing hyperalgesia? Simply reducing and taking away the old drug is a therapeutic intervention. So I think the key is doing this safely and effectively. And
I'd bet that if I worked at MD Anderson, I'd probably get the same amount as they did using their 10 to 1, 10 to 1 instead of a 20-1 ratio. Not too far off.
They adjusted too.
And I think
They do also adjust it depending on the situation. I mean, if the patient's in screaming, I mean, it depends. Like you're right. If you're switching opioids, there is going to be a difference in cross tolerance, despite what Dr. Rosielle said in his second post. So we can talk about that. But if you're on the same opioid, I mean, morphine is morphine once it gets absorbed and gets to the receptor. But then is the patient in pain or not? So if you're switching opioids, I would reduce because of lack of cross tolerance. And yes, I do believe in that. But if they're in pain, maybe I would not have reduced as much.
And Drew, so both of our fourth step is individualizing it. We're thinking about incomplete cross tolerance. Sounds like you don't buy that. Tell me your thoughts. Wait, what was the song again? Dissatisfied with opioid?
Unsatisfied. So I think from a pedagogical standpoint, right? You're teaching residents. I have decided at some point a while back, I was done having a 5-minute aside in my precious time with the residents, explaining to them this Baroque and confusing term, incomplete cross tolerance, that I wasn't sure was a relevant concept when it comes to opioid switching. I really want to emphasize that adjusting the dose after the calculation for safety, for knowing that there's a broad individual variability in how people respond to opioids. I think that practice, reducing for safety, reducing for individual variability, right, is very important, especially if you're using equianalgesic tables, which depending which way you're going, prompt us to put people on too much regularly. And so the practice is fine. I think from a pedagogical standpoint, incomplete cross tolerance is a distraction.
So from a teaching standpoint, let me get this straight. It may be confusing. It sounds like you're also focusing more on the safe conversion. What's the term that you used again in Pallimed posts?
So I think, what I talked about was like we should be using the language of safe and effective opioid conversions, opioid switching. And just want to observe that I think the field has been heading this way anyway. Really, when you look at methadone and buprenorphine, right? And maybe to an extent fentanyl, but especially methadone and buprenorphine. I mean, it's been years since I had a thought in my mind, my patient, let's say he was on 15 BID of oral methadone, how much morphine is that equivalent to? Like, I don't even think in those terms. Most of my colleagues I know don't think in those terms either. They don't find it a helpful question. There are parallel questions, which is, again, what's a safe amount of oral morphine per? And to put this patient on, if I was taking them off methadone or putting them on methadone, what is a safe and effective method of doing that? But I'm not asking myself what's equivalent. And again, I would say that, the whole idea of incomplete cross tolerance is really contingent on the idea that there exists out there some sort of equivalent dose. And I think we can move on from that.
Mary Lynn,
I'm sorry, but your assertion that we should all raise our right hand and swear to the deities we shall never utter the word cross tolerance again it reminds me of that TV commercial, the guy with the fungal toenail infection, where he says, it's nothing. And then the doctor says, it's a thing. It's an infection and you're going to give it to other people, which creeps out the kid. This is a thing. My God, Gavril Pasternak is rolling in his grave right now. This is 30, 40-year-old data. I mean, when I say, I bought a new pair of shoes. Okay, maybe they were Ked sneakers. Maybe they were Jimmy Choos. I mean, all shoes are not the same. Just because morphine binds to the mu receptor and oxycodone binds to the mu receptor, we know we have minimally 3 different variants of the mu receptor. Pasternak would say 25. And then when you look at the intracellular mechanisms of how an opioid works and the beta arrestin signaling, which is dramatically different, like buprenorphine, not at all. Fentanyl is a strong beta arrestin signaler. So I think to say that the consideration of cross tolerance is a Baroque and outdated and fuddy-duddy concept is I think if you can't run with the big dogs, you should stay on the porch. I think this is an important concept, and I think we can simplify it for our learners, but they do need to understand it. It is a thing. It's a thing. Go get some fluconazole. It's a thing.
I wish I had all those phrases of Mary Lynn McPherson in my head.
Feel free to borrow.
But I also hear Drew's point, though, that it's more about how do you teach these concepts? Like if you have, which most of us have, a limited amount of time to do teaching around pain management, how much do we want to focus on, concepts of mu opioid receptors and all these things versus actually just simplifying into 5 steps and saying that 4th step is really about individualizing and making it a safe switch. Am I hearing you correct, Drew? That's part of this?
I'm going to stick by my position that I'm not going to regularly introduce beta-arrestin molecular biology into my lectures on opioid switching. And I feel very sincerely about that. I think we are obliged, and I'm speaking as a clinician educator here. Yeah. I think we are obliged to teach our colleagues and our students in a way that's going to work for them. And my goal is not for them to understand the molecular biology of opioids. My goal is how do I help them convert and switch between opioids in a safe way that's not going to harm my patients. And I think that 5 minutes that I spend explaining things like incomplete cost tolerance is time that I can just say 10 seconds, then we reduce it further because there's a broad individual variation between how they respond to opioids. I think that's factually accurate. And that's my major point.
I have a question. I love the challenging of established practice. We love that on Jerry Pal. So I love that Lynn McPherson came up with a new opioid equianalgesic table. And I love that Drew is talking about, throwing out the table altogether and coming up with a new formulation and also new way of teaching. And yet part of me wonders, so I'm a clinician researcher, right? Like I mostly do research. Is there any reason to suspect that there isn't, what is truth, right? That's a lot of what research is trying to get to. What is the truth? Is there any reason to suspect that there isn't actually some equianalgesic table that is like on average, what we would expect for people? And that ratio going from one, like say, oral morphine to IV dilaudid or hydromorphone, and going from IV hydromorphone dilaudid back to morphine isn't some like reasonable fixed relationship that on average we can say, okay, we go in one direction, it's this way, and we go the other direction, it's the same way, same ratio.
Hypothetically, like if with broad perfect knowledge, right, we could talk about, we could hypothetically have perfect knowledge of in a population what the average or median equianalgesic ratios would be. Sure, right. I guess one of my major arguments is that knowledge is not the same thing necessarily. Obviously, that knowledge is important, and foundational. But it's not the same thing in from a practical standpoint necessarily, in how we teach people how to safely convert. Because again, the whole thing with reducing for individual variation, right, is based in part because of the idea that like we may know, like this, so like the MD Anderson data going from IV hydromorphone, let's say, to oral morphine and showing a 10 times conversion factor, right? That was a population average or maybe median, for those whatever it was, 50, 100 patients,
based on a standard that they have of 10 to 1.
Yeah, right. It was reflective of their practice, right? But let's just take that on face value. It's the best data we've got, right? Yeah. But my argument is that all of us are used to, and then we have these very common standard practices of knocking part of that off, right? For safety, for individual variation, right? For the incomplete cross tolerance, and so our method, the actual method of switching between those things is while it's founded on that data, it's not a 1-to-1 ratio, right? And so my idea is like, let's cut out the middle stuff and just present people a simple way of doing it, or at least simpler, right? I want to be. There's always needs to be room for nuance on patient specifics about how they're doing and how much pain they're in and how frail they are in their mental status, and that's there's no doubt about that. But I think we can make it easier. I don't know.
Rosielle, I'm concerned about oversimplification, for example. I mean, the lines that you have, some's from the old table, some's from the new, some stuff that you particularly like yourself. I mean, my chart, and granted, maybe somebody can come up with a better idea, but mine is based on the very best population-based data in print as of today. I was just looking at a study looking at fentanyl to hydromorphone, which comes out to close to be to 0.2. I have 0.15 in the chart. People, you hit 0.1 in your chart probably if you're using the old chart. I mean, I don't think
there's no fentanyl in my chart.
Not really data based. So I don't think we should oversimplify this to that degree. If you're going to oversimplify that much, you might as well use an online calculator and just adjust and cross your fingers.
Mary Lynn, I'd love your thoughts about Alex's question. Like, is there something as close to a truth as we can get with these tables?
Well, excuse my humility, but I think I did it already. It's the chart that I published. I mean, it is referenced out the wazoo. I don't know how anybody could find any better data to substantiate it. Is it a moving target? Yes. Dr. Rosielle is correct. Something could be published tomorrow to say, oh, nuts, that throws a wrinkle into things. How are we going to address this?
But Mary Lynn, if I could just interrupt. I don't understand scientifically, like how they determine an equianalgesic dose.
Well, that's
like, how do you determine what the like, let's talk about morphine to hydromorphone, because we've talked about that quite a bit. Like, how would you determine what that equianalgesic ratio is?
Well, Dr. Reddy's methodology was all one, you do the conversion, you do the switch, and when the dust settles, what was the median conversion to either get that patient comfortable or keep them comfortable? I mean, that's why we had the 10 to 60 back in the old days, because they said, let's take Dr. Smith and I'll ride my car over his foot. How much morphine does he need to get comfortable? 10 milligrams IV. Great. Let's come back next week and I'll ride over the other foot. How much oral morphine does he need? 60. Great. But if we had left you on morphine 10Q4 around the clock IV, your morphine 6-glucuronide would have kicked in, and it's only 3-1. So we have to look after the fact and say, from a population perspective, what got the job done? It did not make the patient toxic, and it got him in the ballpark. But because of this variability, like even when you look across a line on my chart, looking at hydromorphone, when you look at IV to oral, that is entirely driven by bioavailability. And we have data from 1987 showing it's about 50%, but there's a very wide range. It could be anywhere from 30% to 70%. When you look at the four of us, there is an 11-fold difference in our gut cytochrome P450 enzyme activity and a 30-fold difference quantitatively in our liver. So there's a huge variability from patient to patient to patient. So regardless of which conversion scheme you use, the most important thing is to follow a process. And I think our learners must understand that process, or frankly, I think they're dangerous.
I think Eric made a good point earlier about how, like at MD Anderson, that starting dose is going to bias the data in one direction, right? So if the starting dose is 10-1, then you're more likely to find that, hey, 10-1 works than if you start with 20-1. So I worry that this isn't like a true experiment, like as you were saying, where we can have a laboratory and we can subject people to pain and we can try various doses. It's anchored, so to speak, to that initial ratio with which they start.
But
I think that's right.
But we're looking at people and we're looking at what works. That's why we look at the median conversion, or the whatever number you want to call it, multiplier, divider, divisor, as opposed to, why would we start from ground zero? It's like an antihypertensive. You're going to compare it to the gold standard, for example. It's not just going to be against placebo. They have to wait till the dust settles to say, okay, when we look at 22 patients, the median number most often out of these patients that did the trick was a 12.5 conversion. Now, of course, they're going to start with their 10-1 because that's what they've done for 30 years. Why would they say, let's start with 30 for one, just for giggles, and see how that works out? So, I see your point, but I think looking at the median outcome is the best indicator of where our best shot is.
But Alex, to your point, again, I think, reflecting about our experience the last couple of decades with methadone and now with buprenorphine, right, it's been, I think, a really eye-opening experience for many of us, and realizing that the exactness of this dose may not really matter that much, right, to an extent, right? Like putting people on methadone, I got these patients, I could put them on 5 milligrams BID, I could put them on 7.5 milligrams BID. As far as I can tell, it doesn't matter hugely.
But is that just something special about methadone and buprenorphine?
Well, I don't know, right? And I think the same is true of buprenorphine. So it's not unique to methadone. I would argue the same is true for buprenorphine. And I also think that And this is, again, one of the points I made in the blog post, that especially when we're talking about the low to moderate and doses, 50 milligrams a day of oral morphine, 60 milligrams a day of oral morphine, like, it doesn't matter that much, right? I think these things are to an extent more forgiving. And to that point, so I think why what Alex is saying probably makes an extent. If you're a culture that takes the IV hydromorphone dose and divides it by 20 and puts them on oral morphine, and like that works just fine, like you're going to find that works okay. And if you're on a culture that divides it by 10 and then maybe knocks a little bit more off, you're probably going to find that works okay too, right? And when one of the final points that I was trying to make in my blog post, which we don't have time to talk about today, but is that the other sort of like skeleton in our closet here is that all of these tables that are out there they don't have this huge asterisk and caveat saying none of this should apply at very high doses, right? We present them like these ratios are linear across all doses, and that converting someone off 40 milligrams of morphine, we should put them on the same ratio of hydromorphone as if it was 400 milligrams of morphine or 800 milligrams of morphine.
I'm hearing from Mary
I don't think
Lynn,
that's right.
Like in her process, it's not like the fourth step is about individualizing. Mary Lynn, your thoughts on that? Higher doses, lower doses, what do you think?
Yeah, I think that's all
what that is. Yeah.
If somebody's on a Godzilla dose of morphine, maybe they're having some hyperalgesia, and we shouldn't give them full credit for that dose. I agree.
Well, last question for both of you. We meet again in 10 years to do another equal analgesic table talk. What do you think we're going to be doing in 10 years, Drew?
Oh, I mean, what my hope is that in the next 5 years, additional reasonably good clinical data emerge about this. And people are going to try to smash that data into equianalgesic table and realize, oh my God, I'm adjusting the morphine thing here, but now it's, and realizing all these problems that each caused by having fixed and bidirectional things, there's going to be more appreciation.
So in 10 years, are we all going to be using an app that does that for us?
So we're going to be using Dr. McPherson's data and using a conversion, a more simplified, streamlined conversion table.
All right. Lynn, 10 years from now.
10 years from now,
we're still using your book.
The fourth edition of my book will be out. I think we'll still have an equianalgesic conversion table that we will continue to refine with better population-based data. And whether you use that or you do use an app, the app will hold your hand better through the process and not just plug and chug.
Great. And maybe teach you what it's doing behind the scenes.
That would be lovely.
Can I answer?
Yeah, Alex.
Here's my answer. We'll be using buprenorphine because it's a much better medication with a less addiction potential and a ceiling effect on side effects. And because we'll be using that almost exclusively, there'll be much less need for opioid equianalgesic tables.
And my answer,
buprenorphine just can't go on a table, right?
My answer is in 10 years, we're going to have the exact same spirited discussion about what's wrong.
We will reconvene.
What should we do?
On my calendar.
We'll have $1,000 a month beta arrestin modulator.
Okay.
and it'll be a whole new world.
Well, with that, maybe we're going to all end this podcast dissatisfied. Alex, do you want to do a little bit more of that song?
Look me in the eye and tell me you're satisfied. Hey, are you satisfied? I'm so dissatisfied. Hey, are you satisfied?
I love it when the song perfectly encapsulates the podcast. I honestly really want to thank both Lynn and Drew for being on this podcast, sharing their opinions. I agree with what Alex said earlier. The only way that as a field we move forward is if we, think about where our dogma comes from, thinking about it doesn't need to change. Lynn, love your book. We'll have a link to it on our show notes. Everybody who hasn't read it should buy the book. If you've read it before, read it again. And Drew, really want to thank you again for stimulating this really interesting discussion about EATS, equal analgesic tables. I just want to see Lynn's face right when I said EATS.
I'm going to go eat a cookie now, I think. Thank you.
Thanks for having me. Yeah, appreciate it.
And as always, thank you, Archstone Foundation, for your continued support, and to all of our listeners. We'd also like to thank the generous support from our listeners who've donated $250 or more to the Jerry Pal podcast, including
Meg Walhagen, Thomas Quinn, Rochelle Bernacki, Louise Aronson, James Tulsky, Arden O'Donnell, Mike Steinman, Marianne Forcia, Ashok Krishnaswamy, Nancy Lundeberg, Gail Cooney, David Schiffling, Cheryl Phillips, Jessica Ng, Harry Hahn, Elizabeth Chung, Kathy Foley, Rochelle Bernacki, Christine Ritchie, and Lloyd Woolstat. Thank you very much.